Welcome to the Deep Dive, where we take a stack of information and really try to unearth the most fascinating nuggets. Today, we're stepping into a world that, honestly, for many people, is a complete blank. The world of intravenous anesthetics. I mean, these are the compounds that make modern surgery, procedures, even critical care possible. They induce states from, just calm all the way to profound unconsciousness. It's a field that demands just incredible scientific precision and a huge amount of responsibility. So our mission today is to unpack the pharmacology, the clinical uses, and maybe most importantly, the crucial safety aspects of these remarkable drugs. We've gathered some really in-depth source material, and you're about to get a shortcut, basically, to being truly well-informed about what actually goes on behind the scenes here.
Yeah, and what's so compelling, I think, is that, well, the end result, sleep or sedation might seem straightforward. The science behind it, the careful choices, the considerations, they're anything but simple. We'll be looking at a whole spectrum of medications today. Each one has its own unique personality almost. We want to help you understand not just what they do, but why they're chosen, why they matter, and crucially, why safety is just paramount when using them.
Okay, let's unpack that right from the start then. Because our sources, they immediately hit us with something absolutely foundational: medication prep and safety. This isn't just like good housekeeping, it's life-saving protocol. You have to imagine, right? Preparing a drug that's going to profoundly alter someone's state. Every single step has to be perfect.
Absolutely. The rigor really comes from the high stakes involved. We're talking about preventing contamination, ensuring patient safety at every single turn, preventing errors that frankly can have devastating consequences. I mean, organizations like the CDC and the AANA, their guidelines are crystal clear. You drop one medication at a time. Always, and always in that designated clean area of the OR. Wash your hands before, wash your hands after. Use a new sterile syringe and needle for drawing up, and this is critical. Use a new sterile syringe and needle with each patient, no exceptions.
Right, so it's all about completely eliminating any chance of cross-contamination. Okay, and our sources also make a clear distinction between single-dose and multi-dose vials. That seems pretty important too.
Vitally important. So single-dose vials, SDVs, they're intended for one patient, one procedure, period. They don't contain antimicrobial preservatives, which means once you open them, harmful bacteria can grow relatively quickly. Any leftover medication, discard it immediately. Now, multi-dose vials, MDVs, they contain more than one dose. They can be used for multiple patients, but only if you follow absolutely strict aseptic technique. And while MDVs usually have a preservative, it's crucial to remember this preservative does nothing against bloodborne viruses. Think hepatitis B, C, HIV, nothing. So once opened, you date the MDV and you discard it within 28 days, or sooner if the manufacturer says so, or if you ever question its sterility.
Wow, okay. That level of rigor, it makes you think. With safety being that critical, what would the perfect IV anesthetic even look like if we could design it from scratch? Our sources give us this, ultimate wish list. You'd want rapid onset, rapid metabolism, minimal hit to the heart and lungs, no histamine release. Definitely non-toxic, non-carcinogenic, no weird neurologic effects. And hey, while we're wishing, maybe add pain relief, anti-nausea effects, maybe even protect the brain or heart.
Exactly, and that's the challenge, right? This ideal list is incredibly demanding. It really highlights the delicate balancing act that practitioners face every day, selecting the right agent, administering it carefully. Every drug we'll talk about today hits some of these marks, sure, but finding one that checks every single box, that's pretty much unheard of. It really underscores the complexity here.
Okay, so let's dive into some of the specific players then. Starting with one that maybe people recognize by its look, that distinctive milky white liquid, Propofol, sometimes called Diprivan. Sounds like a real powerhouse in the OR. It's a short-acting 5E sedative hypnotic, works on GABA receptors, right? Enhances their inhibitory effect.
Precisely. It modulates those GABA receptors, boosting GABA's natural calming effect. This increases chloride ion flow into neurons, hyperpolarizes them, making them less excitable. And its rapid onset, usually just 30 to 60 seconds, is why it gets that nickname, milk of anesthesia. Combine that quick start with rapid metabolism, mostly in the liver, and quick excretion by the kidneys. Well, patients wake up fast, feel pretty clear-headed relatively quickly. Minimal residual sedation. That makes it incredibly versatile for induction, procedural sedation, even rapid sequence intubations.
It almost sounds too good. So what are the big safety flags? What do our sources really warn us about with Propofol?
Yeah, there's the paradox. It's incredibly useful, but it has what we call a narrow therapeutic index. That means the dose difference between effective sedation and, well, too much sedation or even dangerous side effects is quite small. You need precision.
Yeah.
And critically, this is huge. It's an emulsion, and it's very favorable to bacterial growth. Once you open a vial or draw it into a syringe, you absolutely must discard it within 6 hours. Tubing used for infusion. Discard it within 12 hours. These aren't suggestions, they're strict rules to prevent infection.
So it's a real tightrope walk. Amazing versatility, but you need extreme precision and constant vigilance about contamination. You mentioned some benefits like anti-nausea, anti-itch, anticonvulsant.
Right.
But it's crucial, our sources say, propofol is not an analgesic, right? It doesn't kill pain.
Correct. No pain relief from propofol itself.
Yeah.
And another important point, it is not a trigger for malignant hyperthermia, which is a rare but dangerous reaction to some other anesthetics.
Okay. What about common side effects?
Dose-dependent hypotension lowering blood pressure is common. That's due to vasodilation, relaxing the blood vessels. Also respiratory depression, especially at higher doses. Breathing can slow down or become shallow, and patients often complain of pain right at the injection site. That's mostly due to the lipid emulsion it's mixed in. Rarer but serious effects include Propofol Infusion Syndrome, or PRE. That can happen with long-term, high-dose infusions and lead to things like lactic acidosis. Anaphylaxis is also possible, even on first exposure.
That brings up a couple of myths our sources tackle head-on. First, egg allergies. Lots of people worry about this.
Right. Most egg allergies are to the albumin in the egg white. The lecithin in propofol comes from the egg yolk, so generally there's no cross-reaction. It's usually considered safe. Also a specific formulation note. Propofol-containing benzyl alcohol should be avoided in premature infants.
And the big one, mixing it with lidocaine in the syringe to reduce injection pain. I hear about that sometimes.
Yeah, our sources are really explicit here. Don't do it. Mixing them can actually cause the oil droplets in the propofol emulsion to coalesce, to clump together. That could potentially lead to pulmonary emboli, which is incredibly dangerous. Plus, research actually shows it doesn't significantly reduce injection pain anyway. So, all risk, no real proven benefit.
Okay, so if you do want to reduce that injection pain, what are the options?
Better options are injecting into a larger vein, like in the crook of the elbow, the AC fossa. Using a larger gauge 5E catheter, maybe 20 gauge or bigger, making sure the blood pressure cuff isn't on the same arm or inflating during injection. Some people suggest pre-treating with a small dose of an opioid just before the propofol.
Got it. And thinking about its broader effects on the brain, it decreases oxygen consumption, CMRO2, blood flow, and intracranial pressure, ICP. Good for neuro cases sometimes.
Yes, and cardiovascularly, it drops systemic blood pressure, cardiac output, and systemic vascular resistance, SVR, because it relaxes blood vessels. Heart rate usually stays about the same, though.
And lungs. Dose-dependent depression of ventilation. Breathing slows down.
Right. Decreases tidal volume and respiratory rate. It blunts the body's normal response to low oxygen levels, too. Though interestingly, the lung's own mechanism to constrict blood vessels in poorly oxygenated areas, hypoxic pulmonary vasoconstriction, remains intact.
Any other weird effects?
Occasionally, you might see green urine that's due to phenols being excreted, or cloudy urine from uric acid crystals. Nothing usually dangerous, just interesting. It also decreases pressure inside the eye and can slightly inhibit platelet function.
Okay, let's pivot now. Let's talk about Etomidate or Amidate. Our sources position this as the go-to when cardiovascular stability is absolutely critical. Another sedative hypnotic, mainly for induction, but the key difference is minimal heart effects.
That's its claim to fame, largely. It provides sedation and hypnosis with very little depression of cardiovascular function. Like propofol, no intrinsic pain relief. Quick recovery, short duration, maybe 3 to 5 minutes. Excellent choice for rapid sequence intubation, especially in unstable patients.
How does it work differently?
It also enhances GABA-A receptor activity like propofol and benzodiazepines, but maybe through slightly different interactions with the receptor subunits. It increases the frequency of chloride channel opening, boosting that inhibitory neurotransmission. Pharmacokinetics, very similar speed to propofol, rapid onset, 30-60 seconds, short duration. Metabolized quickly in the liver by enzymes and also by esterases in the plasma, excreted mostly in urine.
So here's that quirky thing our sources brought up. Propofol burns on injection, right? Because of the lipid emulsion. But Etomidate is also on a lipid emulsion, often propylene glycol, actually, but it typically doesn't burn nearly as much, or sometimes not at all. Why the difference?
Yeah, it's fascinating, and honestly, the sources say we don't have a definitive single answer. The mechanism isn't fully understood. Theories include differences in pH, the specific formulation propofol being a phenol versus Etomidate being an imidazole.
Yeah.
Maybe the speed of injection plays a role. It's still a bit of a puzzle. But the practical observation is clear. Less burning with Etomidate generally.
Okay. Dosing is usually around 0.2 to 0.4 milligauge kilogram I for induction, single bolus, adjustments needed for elderly or liver issues. CNS effects, rapid sedation, amnesia, and it's a potent cerebral vasoconstrictor, so it lowers intracranial pressure, which is good.
Right. And the cardiovascular effects, again, that's the key benefit. Minimal depression, hemodynamic stability. That makes it so valuable for patients who are perhaps bleeding or have heart failure or severe valve disease situations where you absolutely cannot tolerate a drop in blood pressure. Respiratory depression is generally minimal too, but you still need to be cautious.
Okay, but it's not perfect. What are the downsides, the adverse effects?
Myoclonus is pretty common. Those involuntary muscle twitches during induction can look a bit like a seizure sometimes, but usually isn't. The most significant concern, though, especially with repeated doses or infusions, is adrenal suppression. Etomidate inhibits an enzyme called 11-beta-hydroxylase. That enzyme is crucial for producing cortisol, the body's main stress hormone. So inhibiting it can blunt the patient's stress response.
Which could be bad in certain situations.
Exactly. Think about septic patients or trauma patients hemorrhaging. They need that cortisol surge. So using etomidate in those contexts requires careful consideration, especially if prolonged use is anticipated. Pain at the injection site can also happen, and some nausea or vomiting.
So it's this critical trade-off again, amazing hemodynamic stability, maybe the best we have for induction agents, but weighed against that risk of adrenal suppression, a tool for specific high-risk situations used with awareness.
Precisely. It's about choosing the right tool for the right job, understanding all the potential implications.
All right, next up, ketamine. This one sounds truly different. Developed back in the 60s, related to PCP. Angel dust. Wow. Our sources say it creates dissociative anesthesia. What does that even mean? Patients feel separated from their environment.
Yeah, that's a good way to put it. It's a unique state. Patients appear awake, their eyes might be open, they might make muscle movements, but they're not consciously aware of their surroundings in the usual sense. And crucially, it provides profound analgesia, pain relief, and amnesia. Its mechanism is different too. It's primarily a non-competitive antagonist of the NMDA receptor, blocking the action of the excitatory neurotransmitter glutamate. It's highly lipid-soluble, so it zips across the blood-brain barrier very quickly.
Okay, rapid onset, like 1-2 minutes for you, and shorter duration, 10-20 minutes maybe, but variable. Liver metabolism, active metabolite, norketamine.
Correct, norketamine. It has about a fifth to a third of the potency of ketamine itself, so it contributes to the lingering effects.
So what are the key things clinicians need to know when using ketamine? Our sources mentioned a couple of important points.
Yes. One big one is managing the potential side effects upon emergence. The dissociation can sometimes manifest as hallucinations, vivid dreams, or general confusion, sometimes called emergence delirium. Giving a benzodiazepine, like midazolam, concurrently can significantly reduce the incidence and severity of these reactions. This is especially important for patients who might find these experiences particularly distressing, maybe someone with PTSD.
Makes sense. And something about secretions.
Right. Ketamine can increase salivary and bronchial secretions. Using an anticholinergic agent like glycopyrrolate or Robinol can help dry those up.
And it's good for non-opioid anesthesia strategies.
Absolutely. Its strong analgesic properties make it a valuable component of multimodal pain management, helping to reduce reliance on opioids.
Okay, dosing. Induction is 1-2 milligauge kilograms IV, but it's used for pain too, like 0.5 milligauge kilograms for procedures like burn dressing changes.
Yes. Smaller boluses for analgesia during painful procedures, or even as a continuous infusion at very low doses, like 0.1 to 0.5 millikilograms per hour for ongoing pain management. And it can be given IM, intramuscularly, which is really useful in specific situations, maybe uncooperative patients, children, patients with developmental challenges where getting IV access is difficult up front. IM dose is higher, around 4 to 8 milligrams.
What are the common side effects we need to watch for, besides the emergence phenomena?
A major one is its effect on the cardiovascular system. Ketamine stimulates the sympathetic nervous system. This typically leads to increased blood pressure, increased heart rate, and increased cardiac output.
So potentially problematic for someone with severe coronary artery disease.
Potentially, yes. The increased cardiac workload and oxygen demand needs to be considered carefully in those patients. It also commonly causes nystagmus, those rapid involuntary eye movements, which can be an issue during eye surgery.
And the ICP effects. You mentioned it's a cerebral vasodilator.
Yes, it increases cerebral blood flow, which can increase intracranial pressure, especially in patients breathing spontaneously. However, if the patient is intubated and their ventilation is controlled, particularly with mild hyperventilation, ketamine might actually decrease ICP or have a minimal effect. It's context dependent.
Interesting. High doses can cause burst suppression on EEG, like Propofol. But unlike methotrexate, it doesn't lower the seizure threshold.
Correct. It's generally considered safe in patients with epilepsy. And cardiovascularly, that sympathetic stimulation is usually transient but noticeable.
What about breathing?
That's another unique aspect. Ketamine generally maintains the patient's respiratory drive and airway reflexes much better than many other agents. The response to CO2 is usually preserved. PECO2 might increase slightly, but significant respiratory depression is less common unless it's given very rapidly or combined with opioids. That preservation of airway reflexes is a major advantage in certain scenarios.
Okay, shifting gears now to a class of drugs that many people might have actually heard of or even taken, benzodiazepines, benzosis. The first one, Librium, synthesized way back in 1955. These are really versatile sedative, anxiolytic, hypnotic, anticonvulsant, muscle relaxant. But our sources highlight something specific. They cause amnesia, perhaps even more reliably than they cause deep sedation, specifically anterograde amnesia. Can you explain that?
Sure. Anterograde amnesia means difficulty forming new memories while the drug is active. So a patient might receive midazolam before a procedure, be awake enough to follow commands, but later have little or no recollection of the event itself. This is often a desired effect for uncomfortable or anxiety-provoking procedures. Their mechanism, like Etomidate, involves enhancing the effect of GABA at the GABA-A receptor. They bind to a specific site on the receptor, making GABA more effective when it binds. They don't activate the receptor on their own, but they boost GABA's inhibitory action, increasing chloride flow into the neuron.
Okay. They get absorbed quickly. Onset and duration vary a lot depending on which specific benzo we're talking about. Metabolized in the liver. Let's touch on a few common ones. Midazolam.
Midazolam, or Versed, very popular.
Yeah.
Rapid onset, short duration. Ideal for procedural sedation, pre-medication before surgery. Can be given IV, IM, even orally or intranasally, especially for kids. Lorazepam or Ativan. Slower onset, longer duration than midazolam. Good for longer-lasting anxiety relief, maybe preoperative sedation the night before surgery.
And diazepam.
Diazepam or Valium. Even longer acting, often used for its muscle relaxant properties, managing alcohol withdrawal, or sometimes as an adjunct.
Typical 4-DO dose for midazolam sedation might be around 0.05 to 0.1 mg/kg. Of course, doses need adjusting, especially for elderly patients or those with liver problems.
Yes, elderly patients are particularly sensitive. They often need significantly lower doses to avoid excessive sedation or confusion.
Benefits include that rapid onset, good control over sedation levels, the anticonvulsant properties.
Minimal cardiovascular effects compared to, say, Propofol, which is an advantage.
But the side effects, drowsiness, dizziness, decreased coordination, respiratory depression, especially if combined with opioids or other sedatives.
Right. Synergism is a big concern. Combining benzodiazepines with other CNS depressants significantly increases the risk of respiratory depression and deeper sedation than intended. They can also suppress the HPA axis, similar to Etomidate, but usually less pronounced, and they can depress the swallow reflex.
And that amnesia, while often good, it brings up an interesting ethical point you touched on earlier, and our sources mention it too. When we intentionally erase or alter a patient's memory of a procedure, what does that really mean for their experience, their autonomy? How do we balance the need for comfort and preventing distress with a patient's right to fully understand and recall what happened to them?
That's a really profound question, isn't it? There's no easy answer. It's about informed consent, understanding what the patient values, and using amnesia judiciously. It highlights the immense power these drugs give us and the responsibility that comes with using them thoughtfully, considering not just the physical outcome, but the patient's whole experience. And just quickly, if you do have excessive sedation from a benzodiazepine or need to reverse it, there is an antagonist, flumazenil, brand name Romazicon. It's a competitive antagonist at the benzodiazepine binding site on the GABA-O receptor. Given 4, usually starting with 0.2 milligrams. Use it cautiously in patients dependent on benzos or those with seizure disorders, as reversal can precipitate withdrawal or seizures.
Okay, good to know there's a reversal agent. Let's move on to a more maybe modern agent, Precedex or Dexmedetomidine. Our sources really emphasize its unique advantage, providing sedation and some analgesia without causing significant respiratory depression. That sounds huge.
It is a major advantage. Precedex works differently from the GABAergic drugs we've discussed. It's an alpha-2 adrenergic agonist. It acts primarily on alpha-2 receptors in the locus coeruleus area of the brainstem. This action leads to sedation, some pain relief, analgesia, and anxiety reduction, anxiolysis. And the sedation it produces is often described as resembling natural sleep. Patients are typically easily arousable and cooperative.
So less knocked out, more like a deep, calm state they can be roused from.
Exactly.
Hmm.
That's incredibly useful in settings like the ICU, where you want patients on ventilators to be comfortable, but perhaps able to interact or participate in weaning trials. Also great for procedural sedation, where you need the patient to cooperate but stay calm and comfortable without worrying so much about their breathing.
Okay. Rapid onset, 5–10 minute cyberphy. Duration about 1–2 hours after you stop the infusion. Metabolized in the liver.
Benefits are clear. Sedation analgesia with minimal respiratory depression. Patients are cooperative. It can also reduce shivering. Minimal cardiovascular side effects compared to some others, though it can cause issues.
Which are? What are the side effects?
The most common ones are hypotension, low blood pressure, and bradycardia, slow heart rate, especially if given as a rapid bolus. A slow loading dose over 10–20 minutes is usually recommended, followed by a maintenance infusion. Dry mouth is also common. Rarely you might see significant bradycardia or hypotension or even paradoxical agitation. Redown hypertension can occur if it's stopped abruptly after prolonged use.
Okay, so typical dosing. A loading dose of 1 millikilogram over 10–20 mentas, then an infusion of maybe 0.2 to 0.7 millikilogram per hour, still requires careful monitoring, especially heart rate and blood pressure.
Absolutely. But its unique profile, that ability to provide cooperative sedation without suppressing breathing, makes it a really valuable tool in the modern anesthetic arsenal.
All right, finally, let's touch on the real old-timers, the barbiturates, some of the earliest CNS depressants developed. Thinking pentobarbital, thiopental, phenobarbital, methotrexate. Their role has changed a lot, hasn't it?
Dramatically. They were revolutionary in their day, but newer agents have largely replaced them for many indications due to safety profiles. Their mechanism is also GABA-A related, but they act a bit differently than benzos. At clinical doses, they enhance GABA's effect, similar to benzos. But at higher doses, they can directly activate the GABA-A receptor even without GABA present, and they also inhibit excitatory receptors like AANA. This contributes to their profound CNS depression and lower safety margin. They increase the duration of chloride channel opening, whereas benzos increase the frequency.
Okay. Classified by duration, short-acting like thiopental, once the standard induction agent, intermediate and long-acting like phenobarbital, which is still used mainly as an anticonvulsant.
Right. They cause rapid onset of anesthesia due to quick uptake into the brain, followed by rapid awakening as the drug redistributes to other tissues like muscle and fat. But elimination is slower, dependent on liver metabolism, which can lead to that hangover effect.
Any specific clinical nuances still relevant today?
Well, methotrexate is interesting because it actually lowers the seizure threshold. This makes it useful, even preferred sometimes, for inducing seizures during electroconvulsive therapy, ECT, for psychiatric conditions. Barbiturates can also potently decrease cerebral blood flow and metabolic rate, leading to decreased intracranial pressure. They were studied extensively for refractory ICP after head injury.
But did it help outcomes?
That's the key point our sources make. Despite lowering ICP, studies have not consistently shown improved neurological outcomes in head trauma patients treated with barbiturate comas. So their use for that specific purpose has waned considerably due to side effects and lack of proven benefit on outcome.
What are those significant side effects that have limited their use?
They cause significant dose-dependent cardiovascular depression, primarily vasodilation, leading to decreased blood pressure, often with a compensatory increase in heart rate, and significant respiratory depression. They depress the brain's respiratory centers quite profoundly. They can also affect monitoring, altering somatosensory evoked potentials, SOPs, and chronic use induces liver enzymes, accelerating the metabolism of other drugs. Plus, they can trigger attacks in patients with acute intermittent porphyria.
But there's one really serious adverse effect mentioned, intra-arterial injection.
Yes, this is a catastrophic complication. If a barbiturate, especially thiopental, is accidentally injected into an artery instead of a vein, it causes immediate intense vasoconstriction and chemical irritation. This leads to excruciating pain. The limb might blanch, then become cyanotic, and it can result in thrombosis, gangrene, and permanent nerve damage, potentially requiring amputation. It's an anesthetic emergency. Anaphylaxis is also possible.
Wow. Okay. That potential for severe tissue damage really highlights why newer agents with better safety margins are generally preferred today, doesn't it?
Absolutely. While barbiturates were groundbreaking, their narrow therapeutic window and severe potential complications underscore the progress made with agents like Propofol, Etomidate, and others, offering more targeted effects with generally wider safety margins.
So wrapping this all up, what's the big takeaway for you, for our listeners? We've gone from Propofol, the milk of anesthesia, through the unique journey of ketamine, the stability of Etomidate, the targeted sedation of Precedex. We've seen these incredibly strict safety protocols, that elusive ideal anesthetic profile, and the really diverse ways these drugs achieve their effects. It's a lot.
It really is. I think if we connect it all back, it just highlights the sheer amount of thought, scientific precision, and continuous research that underpins what might seem like a simple act, calming someone or putting them to sleep for surgery. Each drug we discussed is like a specialized instrument. It's chosen carefully for its specific notes, its benefits, its risks, and tuned precisely to the individual patient and the specific clinical situation. It's a field demanding incredible knowledge and responsibility.
A world of incredible power and, yeah, equally incredible responsibility. And maybe a final thought for you, the listener, to chew on. Given how profoundly these compounds can affect consciousness and memory, sometimes intentionally erasing recall, what does that mean for our experience of healthcare? How do we, as a society and as individuals, think about the balance between the undeniable need for comfort and amnesia during difficult procedures and our fundamental human experience of awareness and memory? Something to consider.